Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will continue the CAPI program, episode 2. As we all know, that the CAPI program is coronary angiography, a prospective innovation. It is a series of self-experienced perspectives of coronary intervention, innovative tips and tricks. Today we will discuss the second episode under title of Applicability of ELSHAFEY speculation for better visualization of a variety of ambiguous coronary artery lesions. As we know from the first episode about the Galileo illusion and how the inverted grayscale mode of the coronary angiography could delineate and clearly clarifying ambiguity of different coronary ambiguous coronary artery lesions, as we see in the last episode for ostial occlusion of the proximal RCA and flush of the aorta. Today we will continue with the applicability of ELSHAFEY speculation in different coronary ambiguous coronary artery lesions. Case 1, as we know, we will revise it fastly. This case was the previous case. There was an ambiguous aorto-ostial right coronary artery total occlusion in which a regular angiography couldn't clearly demonstrate the entry point. With shifting to the inverted grayscale mode, the tapering pattern of occlusion, proximal stump of the artery, was clearly seen to allow crossing the guide wire successfully. As we see here, this is the regular angiography, and as we see the cuspogram of the right coronary cusp, no clear stump of the ostial RCA, and when we shift it to the inverted grayscale, we clearly see this tapering stump, which allowing me to pass wires and finish the procedure. The second case is case 2, where there was an ambiguous in-stent restenosis in a curved bend along the mid-RCA, which couldn't be seen clearly with regular angiography. And with the activation of the inverted grayscale mode, significant in-stent restenosis could be seen clearly, leading to the consideration of stenting it. As we see here, this is the regular angiography. There is a debatable lesion here. When I shift to the inverted grayscale, as you see here, it is so clear that there is intra-stent stenosis. The third case, there was a totally occluded mid-RCA with high thrombus burden. During wiring of the occluded segment, the wire course was unclear, resulting in the free of dissection at the boundaries of the artery, as well as the thrombus were not well delineated. However, once the inverted mode was activated, the posterior wall of the artery and the thrombus could be visualized clearly. Thus, the application of the ELSHAFEY technique in this case led to the successful results. This is the right coronary artery, as we see. There is a mid occlusion, and it was unclearly. There is a thrombus, but literally the delineation of its boundaries is unclear. So when I inverted to the shifted to the inverted grayscale, you see this is the anterior boundary of the thrombus, and there is a small busway behind the thrombus. The wire obviously turned to the posterior wall, and it was very unclear if it is in a dissection plan or in behind the thrombus, but luminal. So when you be using this inverted grayscale, it was very clearly that it is inside the lumen of the artery, but behind the thrombus. Case 4, in a triad to open CTO of the RCA, integrated approach was attempted but failed. While reviewing the angiographic images to select appropriate guide wires, depending on the presence of microchannels, inverted grayscale mode was used. It revealed that there was marked tortuosity of the microchannels inside the CTO segment with very sharp bends, which was the cause of failure of the antegrade approach. Hence, retrograde approach was used as an alternative strategy. As we see here, this is the right coronary ostium and there is the catheter. While I'm trying to push the wire, it was stopped here. Irregular angiographic pattern, no clear functional track within here, but when we invert the mold, as you see here, the microchannel takes different two acute angles, which was very difficult to wire it because of this tortuosity of the microchannel inside the totally occluded segment. The case 5, in a case with VTO-RCA with a bunch of bridging collaterals, difficulty was faced in selecting the most direct and adequate sized collateral according to the Gerald-Werner score. However, on inverting the grayscale with a microcatheter supporting a guide wire succeeded to cross to the distal cap and complete revascularization was accomplished. As we see here, this is the ambulance lift catheter engaging the right coronary artery, and as we all see here, there is a very bunch of bridging collaterals of the mid proximal to mid totally long segment, CTO segment, but there is a lot of bunch of bridge collaterals. It was very difficult to select the appropriate and the sizable micro channel to cross through it. And in the second view, as we see here, it was we selected this micro channel, which was very sizable, and its course is clearly seen from its beginning to the distal, behind the distal cap. So the microchannel traversed by guide wire supporting by microcatheter, and the procedure is finished. So to conclude, from all of the above case demonstrations, we can conclude that inverted grayscale angiographic mode may be reused in a refashioned manner to tackle most of the angiographic ambiguity or ambiguous coronary lesions encountered in our daily practice. Thank you.